This case will be called the last retreat. Okay? The history of the patient is that of a 65-year-old male who had multiple sclerosis. And several years ago, he received special treatment for multiple sclerosis, and he received Norantrone, which is Mitoxantrone. So that was the history of the patient. And 9 years later, that's when I saw him, he presented with progressive dyspnea and basically with classic heart failure. But now let's go to the echo and let's take a look at how the echocardiogram looks in this patient. Okay, let me just go into the database. Yeah, okay, here we are. Okay, so this is now the patient, and I think it will not be very difficult to see what his problem is when you see this parasternal long axis view. This is also something that should remind you that echocardiography is so extremely powerful. All you need to do is just to put the transducer on the chest and you immediately get information which is so valuable. But aside from the fact that the patient obviously has poor left ventricular function, there's just so much more information in this image, and that is what I'd like to show you in this case. Okay, but before I do so, let me just click through the images, and I want you to try to pick up the information, and I want you to, in a way, decide what you think is the prognosis of the patient, what you think the symptoms of the patients are, and ultimately what we could do with the patient. So just imagine you are now in the driving seat, and just from this echocardiogram, try to derive all the information you can, and then come to a final decision as what you think the patient, well, first of all, has, what his problem is, maybe even why he has the problem, and then ultimately what his clinical situation is. Okay, so here we're now taking a look at the parasternal short axis view at the pulmonary level. Maybe just something that I'd like to show you which has nothing to do with the case in particular, but is something that often leads to some form of confusion. What you see here is pulmonary regurgitation, obviously. And very frequently you will see a small jet further down here. This is clear. This is in the middle of the valve. But this little jet here sometimes leads to confusion. People think that is some kind of aortic pulmonary window or some shunt between the aorta and the pulmonary artery, which it obviously isn't. You have to imagine the pulmonary valve is kind of a valve which is a bit not really flat, but has kind of a doming appearance, and this is one portion of the valve which is just on the rim, and that is where the jet originates. So this is certainly not anything pathologic, but it's just a second jet of PR. Okay, but let's go back to the case. Here is his left ventricle. In this view, take a look at not only left ventricle, but also at the other features. Okay, this is the flow velocity across the LVOT. You have the measurements here on the side. Heart rate of 71, LVOT velocity time integral of 15. Okay, maximal velocity of 0.83. Okay. By the way, if you have questions, you can always answer the questions. Remember, you have this little toolbox on your computer. If you enter the question and send it to me, we'll be glad to pick it up and I'll try to answer the questions. But this is the 2-chamber view now. Okay. This is the 5-chamber view looking at the aortic valve. Here again is the LVOT velocity, this time with continuous wave Doppler. Now here we have the tricuspid regurgitant signal. And let's take a look at pulmonary pressure, which is 3.3. Okay. And just to give you a 3-chamber view as well, obviously you want to judge regional wall motion abnormalities too. You can do that as well. Okay, good. Subcostal view. Okay, now have all of you come to a conclusion as to what his problem is? Okay, now I'll give you my conclusion and I'll give you my little notes on how I see this study. Well, the first interesting thing is that the patient has very poor left ventricular function. So he has cardiomyopathy, and the question always is, why does someone have cardiomyopathy? Remember, in many cases we do not know, but in this case the patient had a special form of treatment for multiple sclerosis, which is novandrone. And this is a substance which can cause cardiomyopathy. And it's not infrequent that you see cardiomyopathy develop after many, many years after taking the drug. It strongly depends on the cumulative dose the patient gets, but even after 9 years, the patient can develop a heart failure. And certainly the patient must have had poor ventricular function even before. He might have not been aware of it, but certainly this is could very well be that novandrone is the cause of poor left ventricular function. So he has more or less, I would say, an irreversible form of cardiomyopathy with poor left ventricular function. Now we can calculate the ejection fraction, which I'm not going to do because I don't want to waste your time. But in essence, if I look at function, my clue would be that it is maybe, moderate to severely reduced with an ejection fraction of somewhere in the range of maybe 30, maybe 35, but not more. If you look at the two-chamber view, it looks even worse in the two-chamber view. So I guess I'd settle somewhere around 30%. Okay, that's the first information. But does the ejection fraction really give you the information about prognosis? I mean, I'm well aware of the fact that the patient has, that ejection fraction correlates with all sorts of prognostic parameters. But in this case, in this individual case, I think we have to look at a few more other details. The first thing that I'd look at is I'd look at the motion of the myocardium. And if you look closely, you will see that it's not completely synchronous. There is some degree of dysynchrony here. And if you look at this here, you see that the patient has a bundle branch block. But do you think that it is a classic left bundle branch block or not? Okay, well, I don't think so, because if the patient is such a wide QRS complex and it's a left bundle branch block, you probably see more dysynchrony. And in reality, the patient did have a right bundle branch block and not a left bundle branch block, which rarely leads to significant dysynchrony. Now, this is a very important factor in the setting of this patient, because the option of CRT therapy is probably not something that he would really benefit from. I think if you look at the motion of the wall, lateral and septal, there is not much dysynchrony here. And if you want to get a further information on how dysynchronous a patient is, and if you want to just take a very small, short look at it without much measurements, I still believe in taking a look at the so-called aortomechanical delay. In other words, the time delay from the beginning of the QRS complex to the beginning of outflow of blood. Okay, one might maybe measure it from here. That would be more fair. Okay, now this measurement is something that has been used in the early days of quantifying dysynchrony. It somehow is not being used as much anymore, but I still believe very strongly in this parameter as a very global parameter, which does help you to discriminate between patients who have dysynchrony or not. And the cutoff value is 140. Now, if you look at these values, no matter which part of the QRS complex we're measuring, we're far below 140. This kind of confirms that the patient does not have significant dysynchrony. Okay, but the next thing that I want to turn your attention to is the degree of mitral regurgitation. How severe do you think mitral regurgitation is? Well, I think there's not much doubt that it is very severe. You can see that there is a very broad vena contracta. If I stop the image here, right here, let me see. Here we go. Yeah, there's a very big pisa here and a very broad vena contracta in the range of 0.7, right? So that is no question severe. And if you look at the regurgitation here in a short axis in a two-chamber view, you will see that it is even bigger. And this is something that is very typical for a special form of regurgitation, which I'll be talking about later. But keep this in mind that you have to look at regurgitation from not only one view, but from 2 or 3 or several views. Now, the important thing is that the patient has regurgitation, and under these circumstances, left ventricular function must be looked in a different way, because the patient has volume overload. He has a reduced afterload. So the ventricle will look better than it actually is. So what does this mean for us? It means that we're probably overestimating ejection fraction, and that in reality, even 30 or 35 will not reflect the true function of the left ventricle. So this is the second thing we're looking at. Now, the next thing we have to look at is the right ventricle. And I got a question from Galina, and she wants to know if there's right ventricular hypertrophy. Well, this is a question we can answer right here. In essence, to really quantify right ventricular hypertrophy, one should use the subcostal view. This is the view which I like best to look at right ventricular hypertrophy. Now, here, this is probably the best view to look at it. And what you do is you freeze the image, and then you simply measure here the thickness of the right ventricle, which is something like this. Maybe not so ideal. This would be the right ventricle, which is 0.4, which is still normal. And normal range is about 0.5. Remember, the right ventricle is not as thick as the left ventricle. In this patient, you might even be able to do it in a 4-chamber view. But all of these measurements, keep in mind that they are not easy to obtain, that it's very difficult to really delineate the right ventricular wall, simply because you have a lot of trabecula, a lot of structures in the right ventricle, which can kind of confuse you with the true wall. I mean, where are you going to measure? From here to here, or from here to here? I mean, honestly, I don't believe very much in measurements of RVH. Here, this is a nice view. Look, take a look at this here. Here you see all these trabecula, right? I mean, this is a very irregular surface, and if you've ever seen, you know, a specimen of the right heart, you will realize that the right ventricle is, you know, bizarrely shaped, and there's a lot of different structures in the right ventricle. So, but in essence, to answer the question, I think there might be some degree of RVH, but probably not very much. This is not a patient where the right ventricular hypertrophy is really, you know, up front. But what is very important is right ventricular function. Now, right ventricular function is a very strong prognostic factor, and if we, for example, take a look at this patient's motion here, we see that it's okay. It's not so bad. You see that there's still motion of the right ventricle, especially in longitudinal direction. And if you want to be even more specific, what you can do is you can do the so-called TAPSI, where you basically put an M mode here into the annulus of the tricuspid valve, and then you observe the motion, and all you need to do then is just simply, measure from here to here, and the normal measurements would be somewhere in the range of 17, 18. In this case, pretty normal right ventricular function. Right? You see it moving. The other thing you can do is you can look at the tissue Doppler of the free right ventricular wall. I don't know if we did it in this patient. I guess we didn't do it, but we can do it offline if you want to do it. All you need to do is you put the tissue Doppler here, the lateral wall, and then you have this signal, and you see the systolic motion right here. This is the QRS complex, systolic motion, and then all you need to do is just simply measure the peak here, and you have a velocity of 0.77, which is, in essence, a bit lower than normal, but the offline method usually gives you lower values. So I would say it's still in the range of, I would say, normal, maybe not supranormal, but in the low normal region, which is an important information, meaning that the patient does have preserved right ventricular function. Oops, I jumped out of this here. Where is it? Okay, here we go. But going back to the patient, the other issue which is important is the fact that he does have pulmonary hypertension, but pulmonary hypertension is not so severe. So, you know, the pressure here is, the gradient is 44 millimeters mercury. Maybe if we add 5 or 10, we'll get to 54. So there is pulmonary hypertension. I would say moderate, but not severe. But one thing is very interesting, and that is the fact that he has a fairly low velocity across the LVOT. You see, the velocity here is only 15 velocity time integral, which is low. You should have 20, 25, maybe 30, 35. That's what the normal velocities would be, which means that there's not much blood ejected. So he has kind of a forward failure, which might also be due to the fact that he is regurgitating most of the blood back into the left atrium. Now, the other thing that is very interesting is let me see, is the fact that when I go to the M mode of the aortic valve, look at the signal of the aortic valve. You see that the aortic valve opens, but it closes rather early. It's like almost a triangular shape. This means that the blood flow, opens the aortic valve, but then flow kind of deteriorates and the valve closes, which also is an indicative of not very much flow going through the aortic valve. This is an old sign that we've known for many, many years, and in this case it correlates very nicely with the Doppler signal that we see right here. I got a question from Lali Tesh, and she wanted to know what frequency is required for a good Doppler. Well, the frequency, in essence, does not really make so much of a difference. The most important thing in reality is to have good image quality. If you have good image quality, you'll also get a good Doppler signal. This, in my opinion, is probably the best thing to do. And of course, the Doppler signal also improves if you have higher frequencies. You get a higher sample rate also for the Doppler. In essence, that would be something that you would prefer to have. But in reality, you have to kind of use the Doppler frequency, the imaging frequency that gives you the best 2D image as well. And then there was another question by Philippe, the myocardial performance index. Yes, this is something you can do as well. You can take the mitral valve and you can see, how long the ejection period is, and subtract that from the duration of diastole and kind of get the so-called TI index. The TI index is a so-called global performance index. What it is, it tells you something about systolic and diastolic function. So it's like a good or bad kind of a signal. Information. In reality, I'm not much of a believer of this index because it just means if someone is sick or not sick, and it does correlate, of course, with prognosis and many other things, but I don't think it really gives you much additional information aside from that, what you see here as well. Okay, so coming back to this case, I want to wrap this case, or at least this first part of the case up, in the sense that he has, I would say, he has very severe mitral regurgitation, which severely impairs his prognosis. He has low output failure, basically, maybe because of MR and because of poor ejection fraction. But he does not have such severe pulmonary hypertension, and his right ventricle is still okay. Still, the patient was very symptomatic, and in essence, we were, under the question, what can we do with him? He was under full heart failure treatment, but my question to you later will be, what can we do with the patient? But before I answer this question, let me go back to the slides and show you, or ask a question to you. Remember, we have the possibility of asking polls to you, and this is my first question. You'll be seeing it in a second. Okay, I hope you can all see the question. And the question is, what is the mechanism of mitral regurgitation? Is it restrictive leaflets? Is it annular dilatation? Is it leaflet shrinkage? Or does the patient have Barlow disease? I'll give you a few seconds to answer this. Okay, so most of you think it's annular dilatation. You guys are actually right. Let me show you the images again, and then we'll take a further look also at his TE study. Okay, so here you see the image of the four-chamber view, and what you nicely see is you see that the annulus is dilated, and in a way the leaflets are not really coapting. There's only a small part of the leaflets which are touching. But the answer is maybe not as simple. It's not probably only, I would say, a coaptation defect caused by annular dilatation. Here you can see that the level of coaptation is very low. You see that there's very little tenting of the valve, which means that the base of the leaflet just simply pulled away from each other. But the next thing I want to show you his TE study. And then we'll take a further look at its mechanism. Okay. Here's the same patient now in a TE. Here we have again, just very little coaptation here. The level where the leaflets close is almost plain. I'll show you what I mean. You see here, this is the annulus right here, and there's no tenting underneath. Yeah? Normally, coaptation should be something like this. This is usually a true sign that there is some form of annular dilatation. But what also strikes me is that, you know, these leaflets, if you look at them closely, there also seems to be some degree of prolapse. Let me just show you this in slow motion. It's not a, you know, Barlow in the sense of very thick leaflets, but you know, I could very well imagine that this patient had just a mild prolapse to start out with, and then he did have annular dilatation, and so this is kind of a combination. Remember, this is possible, but you see that the leaflet is kind of rolled in like this. This kind of a, you know, motion, a U-turn, as you might call it, here in the posterior leaflet. To take a further look at the valve, we also performed a 3D image. Let me see where the moving images are. Here they go. Here. And here you see the mitral valve in a 3D perspective. Now, 3D is nothing you have to do. And honestly, I think you will probably not get to a different decision or conclusion if you look at, you know, 3D or 2D. But it does help you for teaching purposes. And I want to highlight a few things which I think are very important. The first thing is, okay, we can easily discern an anterior from a posterior leaflet. This is very simple. But what we sometimes forget is that especially the posterior leaflet, but also sometimes the anterior leaflet, has little cusps. We call them scallops. And these scallops can have kind of really deep indentations, so they almost appear as separate little leaflets. And if you look at this region right here, let me just show you, right here, you see that there's kind of an indentation here, maybe even here, and maybe even here and here. What I'm trying to say is that you know, if we have a certain four-chamber view and we cut through the four-chamber view, which would be somewhere like here, and we have a little jet here and here, this is explainable because this is maybe not only an anterior or posterior leaflet, but it's separated into little leaflets which can have all sorts of different jet origins. Okay, this is something to keep in mind, and which is very important when it comes to a special procedure we'll be talking about maybe later. Okay, this is the TE study. I don't want to, yeah, something I wanted to show you here as well, which is also so important and so interesting. Now, this patient was admitted to our ward after he was completely decompensated and he had, you know, heart failure and whatever. And he received diuretics and was treated with, you know, excessive, you know, triple therapy and whatever. And he really improved clinically. And then we performed the TE. In other words, the TE that we're doing here now was done under completely dry circumstances. And if you look at his mitral regurgitation now, he does not look as much as it was before. You know, even in the two-chamber view, you see that this big, broad jet is now more or less, you know, several little jets which kind of show some form of confluence. But the point here is, and the teaching point, and take that at home with you, is mitral regurgitation is extremely dynamic. You can have massive MR, and then you recompensate the patient, and MR is almost gone. But it will reappear because his left ventricular function is poor, and that's what we were afraid of. Okay, Gentiana asked me, is the abnormal motion of the septum due to pulmonary hypertension? Well, I think it is. I think there is. Very good point. Let me go back to this. You guys are asking really good questions. You make you think. You really make me think. But this is a very good point. Look, here you see this abnormal septal motion. You see this? Okay. Now, the patient has pulmonary hypertension, but it's not very severe. Why does he then have abnormal septal motion? The answer is so simple. It's because the pressure in the right ventricle is still so much higher than the pressure in the left ventricle, because the pressure in the left ventricle is so low. Why is it low? Because the patient has low output, right? There is no flow here, and he was very hypotensive. So the abnormal septal motion is usually something which you have to take into consideration as being relative between the right and the left. Okay, this is the answer to Gentiana's question. And Marian asked, would you add heart cath? Well, in essence we did, because in every patient with cardiomyopathy, we have to exclude that he has coronary artery disease, and this is what we did, and he had completely normally coronary angiogram with everything okay. Okay, and Carolina and Dana said this was annual dilatation, which I completely agree with. Okay, but let me go back now to the case, and now we've got this patient. He's recompensated, but he seems to be doing a bit better. But he's lying in his bed, very whiny person, very depressive. And, he's got multiple sclerosis, and he is really in a bad condition. But what do we do with this patient now? I mean, does anybody have an option? Okay, I'll tell you what our option was. Since he was coming back and all the time with with heart failure, we decided we'll do a special procedure with him, which is called the MitraClip procedure. I'm sure most of you have heard of it. It's a new type of treatment which avoids going into surgery and opening up the chest, because by an interventional approach, we can clip the anterior and the posterior leaflet simply together, and thereby cause readaptation, or we can close the coaptation defect to a certain degree. And this is a treatment which has now been ongoing for several months, several years already. There's a number of studies which have been performed that show that it can be effective, especially in functional MR, and it's something that will hopefully be also improved in the US shortly, and then it will be available there as well. And I now want to, let me just show you the procedure. Can you see this video? Okay, this is the video that the company made to show you what the procedure is all about. Some of you might have seen this already. This is the device. It looks like a machine gun, actually. It's a pretty big device with a fairly thick catheter. And on the tip of this introducer, you've got a special clip applicator, and what you do is you use a venous approach, and then you just go transeptal. This is the transeptal puncture. Then you kind of have this wire that you advance, and over this wire, basically what you do is you introduce the device, the MitraClip device. You see on the tip of the device, you see the clip, and then you can kind of flex this clip downwards. It's a pretty neat steering thing that you do from the outside. Very complex. Remember, you have to do that with the help of TE. You cannot do it with catheter. You need TE because only there you can see the valve, because you have to know where the valve obviously is. So then you open up this clip, and you try to see if you have a perpendicular orientation to the valve. You play around with that, and then in essence you simply try to find where the maximum jet is, and then that's where you go into the valve. You advance it inside, and then you kind of withdraw the device, and then just clip the leaflets, and there you go, and mitral regurgitation is gone or not gone. If it's not gone, you just reposition it, and once you've repositioned it and you closed it and you think it's good, you simply release the clip, and once you've done that, the patient has a double orifice. You see one orifice on the left, one on the right, and usually you do not really cause any severe form of mitral stenosis unless you use like several clips, which one can also do. But then the device is retracted, you pull it out, and the clip is in place, and the patient has less regurgitation. Now, obviously, this does not always work as nicely as it is shown here. It's a very, very tricky procedure. I just want to give you a few impressions of what happened in this patient to show you what this approach can do, but maybe also to show you which difficulties we have. Let's go back to the patient. Here we are. So we start out with assessing the valve. Look, regurgitation was almost gone now. I mean, don't let yourself be fooled by this, because we did use provocative maneuvers in the cath lab, and then we did get much more MR. So this is a situation we're confronted with very frequently, that under anesthesia, when afterload and volume is different, that regurgitation is less. Okay, so here we started the provocative maneuver. You see that MR starts to get more. But in essence, what we then do is we acquire certain special views in which we are able to really assess the catching of the leaflets. And then the next step is to perform the transeptal puncture. Let me see where this image is. I can't find it. Well, anyway, so we perform this transeptal puncture. Here it is. Here you see there's some form of lipomatous interatrial septum. Here we have the tenting of the leaflets of the septum. Then we go through, puncture. Here we are through the interatrial septum. This is the introducing wire. And then, in essence, you approach the mitral valve. I think this is a very good image. You can see nicely that the grasping part of the device is open, and then you move the device further into the valve, and what you're trying to do is you're trying to get the leaflets right in between here, and then close the device. Here you see this approach. Now we are right in the midst of regurgitation. You see that regurgitation is a lot more than it was originally, and then basically you close the clip. This can be very cumbersome. Sometimes you need to stop ventilation so the heart does not move as much, and there's often several approaches until you finally get it. Okay, and obviously then finally when you are lucky you will get a good result. I'll just skip to the end. Here we have the clip now in place. There is practically no regurgitation, but it's still attached to the device, and then ultimately we let go of the device. Here it is, and you see there's only very, very little regurgitation left. Isabella asked, can this mitral clip dislodge and cause embolism? The answer is yes. This is something you really try to avoid, and this is the big fear that everyone has. There's several things that can happen. First of all, you can only have partial detachment, which means it's only hanging on one leaflet. And the other thing, it can really dislodge. But I think there's only 2 or 3 cases in the world where that really has happened. It's something that, fortunately is something that which is fairly rare. If you use echo to monitor the moment of really grasping the cusp and when you are sure that you're really there where you are. But let me just conclude with this case because I have so many other things I want to show you as well. I want to conclude just by showing you the final echo of the patient. This is back to transthoracic, and 2 things which are interesting. First of all, here's the clip. That's how it looks. The second thing is you have a gradient across the valve, so you have an orifice which is smaller. But if you don't do too many clips and if you don't completely close the orifice, you will have enough flow that you don't have significant stenosis. But the second issue is that ventricular function now looks much worse. But don't be fooled. Even though ventricular function looks worse, the patient was doing clinically a lot better. Why? Because his regurgitation was less. Here is his regurgitation after the procedure. Okay, so I think we really helped this patient. It's a really neat procedure, very time-consuming, doesn't always work, and I'm sure that there will be a lot of improvements with this procedure in the future, and you'll be seeing much more of this. Maybe I'll be showing you more cases of MitraClip some other time. Okay, so this was the case called Last Retreat.